Okay, welcome everybody to our webinar. We will talk today about thyroid gland and adrenal gland. Okay, so let's start. So our first topic will be about thyroid gland. And talking about the thyroid gland, we already know what is the anatomy, what is the physiology. Just to refresh a little bit, the thyroid gland produces T3, T4. T4 is called thyroxine and produce that calcitonin too. So the TSH produced by the pituitary gland are going to stimulate the secretion of T3 and T4, and independently of the hypothalamus and pituitary, the calcitonin is going to be released by the stimulation of the calcium. If you have too much calcium levels in blood, more than 10.5, that calcium stimulates the secretion of calcitonin. So all these hormones are going to be keep in consideration when we will talk about our pharmacology. Thyroid gland functions is going to be metabolism, growth, and development. Metabolism, why? Because produce T3 and T4. What are T3 and T4? T3 and T4 are hormones that will stimulate the engine of the body. Let's put it that way. It's going to lead us to produce more ATPs. If you have more physical activity, your T3 and T4 are going to be high. If you have some disease, some infection or something, make your body regenerate tissue, the T3 and T4 are going to be elevated. Another thing that you need to remember is that the thyroid gland, the thyroid hormones are going to be elevated when the patient is pregnant. With pregnancy, let's take out the volume. Just a moment. Okay, somebody. Okay, if somebody is pregnant, the T3 and T4 levels are going to increase. Okay, so let me see. Okay, so here we have the other function is the growth and development. And this growth and development, growth, increase size, development, produce the function, especially when we are talking about embryo, right? When we talk about embryo, they need T3 and T4. Remember that embryo produce T3 and T4 by himself, so herself. The T3 and T4 is not coming from the mother. The T3 and T4 are being produced by the own thyroid gland of the fetus, about 15 weeks of gestation. So coming back to the pregnancy, in pregnancy they are going to increase T3 and T4. In addition to that, the thyroid gland will be overstimulated and increase in size during pregnancy. So here we have very brief the anatomy, the thyroid cartilage, so you can tell where is located the thyroid gland. All right. So it's a little bit off the picture from the previous one, but you can tell the location of the thyroid gland. So it's below the larynx. We call that the thyroid cartilage. Okay, so let's keep going. So here we have the relationship of the thyroid gland with different organs. So you can see different structures. You can see how the blood supply. So this is an endocrine gland. Okay, so here let's talk about these are the what we call goiter. Why the goiter is increased? Why do you think the goiter is increased here? The goiter is going to be increased because the most common cause of hypothyroidism, and in hypothyroidism you will have mostly these goiters in hypothyroidism. The major deficiency, the major cause of hypothyroidism will be the deficiency of iodine deficiency. So if you have iodine deficiencies coming from diet, the pituitary gland, means the hypothalamus, is going to know this, that the thyroid gland cannot produce T3 and T4 because we need iodine for that. If you have low levels of T3 and T4, the pituitary gland are going to secrete a lot of TSH, over-stimulating, trying to make the thyroid gland produce more T3 and T4, but there is no iodine to produce. So this hyperstimulation of the hypothalamus pituitary thyroid gland with a lot of TSH are going to make enlarge the thyroid gland. If you can see here in the previous slide, if you have enlargement of the thyroid gland, what is going to compress? Basically, it's going to compress the trachea. So you can have stridor, you can have some narrowing of the trachea, producing some sounds like wheezing, for example. Here we have posterior to the trachea, what we have, the esophagus. Behind the trachea is the esophagus. If the thyroid gland is going to be enlarged enough, they can produce problems in the respiratory and the digestive system. All right, so that was the review for the anatomy physiology. Let's talk about, you already know the signs and symptoms of the hypo and hyper, and this especially in this class, for pharmacology, you must know very, very well the signs and symptoms of hypo and hyperthyroidism. Why? Because if you are hypothyroidism, what you receive T3 and T4. If you are hypo, you receive T3 and T4. But if you receive too much T3 and T4 from hypo, you're going to get signs and symptoms of hyper. And the opposite, if you are hyperthyroidism, you're going to have some substances that are going to diminish or slow down the T3 and T4. So from hyper, if you have too much medication, you can lead into hypothyroidism. Nutrients interactions, we have vitamin A, iron, selenium deficiency, and goitrogens. Vitamin A, iron, selenium, and goitrogens. So we have vitamin A is going to exacerbate the effects of iodine deficiency. So that means more signs of hypothyroidism, right? If you have iodine deficiency as a background. Iron deficiency required to activate cellular response to D3. So the iron deficiency will not, if you have iron deficiency, the T3 and T4 are not going to act effectively in the tissue. Selenium deficiency required to convert T3 and T4. For T3 and T4, please remember this. T4 is the thyroxine, and T3 is the thyronine. We call T3 only. So T4, thyroxine, and T3. Those are the names we use. The active form is the T3. Active form is T3. So T4 means three components, o sea, four components, tetraiodine, thyroxine, and the other T3, they have three. So in order to form T3 is coming from T4. You decompose the T4, and the T4 is going to produce T3. Okay? All right, so and what happened with the remnant? The remnant are going to join another T's, 1, 2, 3, and form T3. So that is about the game. And where is going to happen? In the thyroid gland and in the blood. Goitrogens. Goitrogens suppress T3 and T4 synthesis. Or there is vegetables that will be acting in order to decrease the production. Synthesis means production. Okay, so here we are going to see about the treatment. The goal of the therapy is to return to a normal thyroid state. All right, so please, number one is a lifelong treatment. Lifelong, forever. And these people have sometimes they're hypo, sometimes hyper, and that means that they need to adjust the medication all the time. And for that, you need to recognize what are the signs and symptoms. High yield for NCLEX are the temperature. If you're hypo, you are cold, sensitive to cold. If you're hyper, you are more actually feel more heat. Hot. The bodies become hot. So everybody, if you have hyperthyroidism, everybody is with everybody is going to be covered because it's cold, but the hyper is going to be just in t-shirt, and the opposite in the hypothyroidism. All right, so here we have the two medications that we are going to talk today, the levothyroxine and the levothyroxine. All right, so listen to this. If you cut here thyroxine, this thyroxine alone is the normal hormone that T4 that we produce in the body. But this is make it in the pharmacy as levothyroxine. So it's similar to the thyroxine that they produce, but the difference is an English question here again, is that the thyroxine is going to last longer. Thyroxine is short name, right? But levothyroxine is longer. So levothyroxine, so that's why this medication can be taken once a day, every 24 hours. Okay, so before they was giving the natural form that is actually more difficult to monitor, that was in the past. Now we have this medication, the levothyroxine, for many years already, actually, like once a day. Same for the levothyroxine. So tell me one thing, levothyroxine and levothyroxine. This is the T3. Thyroxine is T4. So T4 need to turn into T3. T3 is immediately is going to make action. So it's going to be faster, the action of the T3 over T4, because the active form is going to be T3. The T4 is not acting because they need to transform before into T3. All right, so that is hypothyroidism. So you are going to give thyroid hormones to the patient with hypo. In hyper, you will have the PTU, the propylthiouracil, and the methimazole. Never giving this in pregnant. And one of the things that they do these medications is to decrease the production of T3 and T4. Again, hyperthyroidism, PTU, methimazole decrease the production of T3 and T4. So that means that the already existent T3 and T4 running through the blood is not going to be affected. So need to be time in order to produce the diminished overall of the T3 and T4. So again, and we have the existent T3 and T4 in blood is not going to be blocked by the PTU and methimazole. Why? Because they are not doing anything there. So what they are doing is to decrease the production of new T3 and T4. All right, so here we have the hypothyroidism, the chart, hyper, iodine, PTU, propylthiouracil, and the iodine 131. As we explained, we are going to talk about iodine 31 in a few moments. All right, so keep the patient in hypothyroidism. The patient is cold. What the nursing, simple nursing actions is going to be to offer some blankets. Okay, so you need to remember that we need to have one of the things we need to remember is the history of prior thyroid problems or cardiac disease. Adrenal gland insufficiency is less common, but focus right now and always remember in the thyroid problems and cardiac. Okay, so thyroid, there is some tendency to be running in the family, number one. Number two, so there is some genetic factor. Number one, that is number one. Number two is that they are 4 times more common in female than male. We don't know exactly the reason, but when you see this big difference, is because there's hormonal levels are going to be the problem. So we have cardiac. Remember, cardiac, it can be in hypothyroidism, we have bradycardia. In hyperthyroidism, we can have the heart rate increase. So be careful with the dose. All right. So thyroid and heart. Okay, so history or list of medications. So we already talked about over-the-counter, like selenium. We have vitamin A. Depression, that is the signs and symptoms of hypothyroidism. The patient is hypo, low, depressed. Nutrition is going to eat. The patient says, I'm gaining weight and I don't know why I'm gaining weight if I eat so little or I was eating as before. Lifelong thyroid treatment and need periodic laboratory tests. How often? Depends. Every month or every 2 months. Mostly the patient is going to be trained by the nurse in order to identify when the patient is having, we need to increase or decrease the dose. When it's out of control, they need to make an appointment in order to have the levels of TSH and T4. One more time, the laboratory test that we use for thyroid gland levels is TSH, right? TSH is produced by the pituitary gland, so we check the TSH and T4. T4. We don't check the T3. Okay, so let's keep going. All right, so not all systems are going to be affected. Moderate exercises, that means that they trying to make an equilibrium, a balance, a steady physical activity during their life, because otherwise the needs of hormones will be different. Okay, so levothyroxine, we have the synthroid, levothyroxine. So you take T4, that's what you're taking. But T4 will be transformed into T3. Liothyronine is the cytomel or Liotrix, is straightforward T3. All right, so we don't need to wait until with the liothyronine to transform T4 into T3. So T3 is the hormone who go to the target cells. So the cells are going to read or going to receive the T3, not the T4. Okay. All right, so actions replace deficiency and T3 and T4. Those are for hypothyroidism. Signs and symptoms of hyperthyroidism. So if you have too much, you're hypothyroid and you receive medication T3 and T4, but if you have too much T3 and T4, you pass in the other side, that is the hyperthyroidism. Heat intolerance, tachycardia. So remember your clinical history about heart. Weight loss. So weight loss. So I was saying that this medication was a long time ago used as to lose weight, not anymore. Can produce diarrhea and hyperglycemia. Hyperglycemia. All right. So nursing considerations, the full effect, and please remember this. The full effect is going to take about 3 to 4 weeks. So we are talking about what? About hypothyroidism. Okay, 3 to 4 weeks. For 24 hours, what does it mean? That the medication is taken once a day. And very important nursing consideration, especially for NCLEX, is the dose of these medications for hypothyroidism are going to be measured based in micrograms. Okay, contraindications, hyperthyroidism, of course, recent myocardial infarction. You don't want to have overload your heart with more contractions, right? Unnecessary. And the T3 and T4, what if you give the medication in excess, overdose, that can produce tachycardia and can produce some risk and problem for recurrent myocardial infarction. All right, so here we have drug interaction, warfarin, need to increase dosage of anticoagulants. So the warfarin need to be increased in dose. How we check the warfarin? With PT, right, or INR. Digoxin, decrease dose of digoxin. Cholestyramine is BABA. Estrogens, anabolic hormone, means build up what? Proteins. And T3 and T4, when they're running into the blood, they will have, they're attached to the proteins. And that is important. Why is important? because estrogens promote the levels of proteins in blood. So there is two types of hormones in the blood. The thyroid hormones. The thyroid hormones attach or link to a protein, and the other ones who are free. So they are not linked to the protein. And guess what? The one who is active is the free T384, the one who is not attached to protein. So if you take estrogen, making OCP or HRT, hormone replacement therapy, they are going to increase the estrogens in blood, increase the anabolism, increase the proteins, increase the link for T3 and T4, means there is less free T3, T4. And that is going to make an effect of the medication. So in this case, you need to increase the dose of T3 and T4. Okay, so this is high yield, please, and this is very important. Open eyes, open ears. Here, the warfarin thyroid treatment lower the level of warfarin. What we need to do is increase the warfarin dose. Digoxin have a synergetic effect, decrease the digoxin dose. We have BABA, cholestyramine, antagonic effect. We need to take it 2 hours apart. Take cholestyramine 2 hours before taking Ligotrix. And the estrogens thyroid treatment decrease the free T3, T4. So what we need to do is increase the T3, T4. All of these are high yield NCLEX. Estrogens, I didn't put it here, it's in red too, but these two, warfarin and estrogen. So those are the common seeds that we need. You must remember, please, okay? So we have nursing interventions of hyperthyroidism. So we already are in hyperthyroidism. Review history as the previous one. Request list of medications. The patient is, they need to have a cool, quiet environment. Maybe it's anxious. So the patient is like, looks like a very nervous, actually, the patient, with tachycardias, with intolerance to the well, they're resistant to the cold. I mean, his body is having a lot of energy, releasing heat. So that's why the patient is having, they are going to use less clothes than for a t-shirt versus a patient who is using a jacket. Okay, so hyperthyroidism assessed for bleeding is going to modify coagulation, fibrinolytic balance, respiratory distress, muscles, and tetany. So when you have an hyperthyroidism, the gland is overstimulated. When this overstimulation of the thyroid gland, they're going to release T3 and T4, but in some way they will be releasing calcitonin. If you release calcitonin, what is doing calcitonin? Calcitonin is taking the excess of calcium into the blood. But in this case, it's secreted without having high levels of calcium in blood. What it's going to do at the end is the calcitonin take calcium from the blood, making hypocalcemic the patient. And calcium is needed for the coagulation factors to react to produce the fibrin. So calcium is part of the cascade of the secondary coagulation that produce fibrin. Calcium are going to be needed for that. Okay, respiratory distress, muscles, especially the diaphragm. The diaphragm is going to have some problems because what is the diaphragm? Is muscle. Again, calcium problems there. Tetany. Tetany is characterized when it's happening hypocalcemia. Hypocalcemia. Okay, so nursing intervention for hyperthyroidism. Iodine-131 is a radioactive substance that will destroy cells that of the thyroid gland that produce too much T3 and T4. So just imagine the thyroid gland, and there is areas that forms as nodules. That nodules are abnormal. So these nodules will work independently, different from the rest of the gland. Independently means that they do not obey the hypothalamus or the pituitary gland. Whatever pituitary or hypothalamus said, these nodules in the thyroid gland do not pay attention. What they do is just release a lot of T3 and T4. So if they produce a lot of T3 and T4, that means that they eat a lot, much more than the rest of the gland iodine, correct? So that is the role here, iodine-131. Iodine-131 is radioactive. So this iodine is going to be collected by the normal cells of the thyroid gland plus the abnormal cells of the nodule of the thyroid gland. Who is going to eat it more? The nodule. So that means that this is going to affect mostly the nodule than the rest of the normal gland, producing the destruction of the nodule and make the patient be into normal state. These antithyroid medicines will take effect about 3 to 6 months. The previous one, when you give T3 and T4 for hypo, 3 to 4 weeks. Here, the opposite, antithyroid is going to take effect from 3 to 6 months. All right, so hyperthyroidism. So side effects, you can have hyperthyroidism. So that means if you're having hyperthyroidism, you take the medication for hyperthyroidism, and you have signs and symptoms of hyperthyroidism. What does it mean? That is not enough dose. But if you have hyperthyroidism, you receive medication for hyperthyroidism, and you have signs and symptoms of hypothyroidism, that means that you have too much medication. All right, so nursing consideration, this is a radioactive substance, so is need to be swallowed by the patient. You need to minimize when you are giving to the patient this substance. Minimize exposure, wear latex gloves, and it's no need to use masks. And be careful with the childbearing age female. Okay, so you don't know if a female is pregnant or not, so you need to just to avoid the contact with fertile age women. Okay, so if the iodine-131 or excreta spills, that means the patient is going to eliminate some radioactivity with the poo, right? So, or urine. So they are going to just have, if there is spill around, you need to just follow the policy and use containers with radioactive waste disposal. Okay, we're talking about the time of the full effect, 3 to 6 months. The patient should be monitored for hypothyroidism and bipolar disorder. Bipolar disorders, yes, bipolar. Bipolar is the obsessive compulsive disorder. And this patient with hyperthyroidism, they become paranoid, become very agitated, confused as schizophrenia, very active, no stop. So that's why he's confused with bipolar, with a maniac face, right? And these patients mostly are sometimes mistake with diagnosis of schizophrenia when they are not. Okay, lithium and iodine 131. So lithium is used for OCD, obsessive compulsive disorders. And this lithium, when this combined with iodine 131, can lead into hypothyroidism. So that means increase the effect of the iodine 131. All right, so lithium, what is doing lithium? Lithium is, if you take lithium, you become calm. But this kind of very tense calm. Well, we will say that, we will see that when we have the class of that. And yeah, that is going to depress the patient, the lithium. So calm down. So iodine 131 is going to decrease T3 and T4, so they can have signs and symptoms or increase the signs and symptoms of hypothyroidism. Okay, nursing considerations. If you have hyperthyroidism, you need to avoid iodine-containing food. What food contains iodine? Seafood. Seafood has a lot of iodine. In the mountains, do we have iodine? So if you go to the mountains, there is no iodine actually in high levels. All the iodine mostly are at the level of the ocean. Why is that? Because the iodine is being, when it's raining, the iodine is swept out from the mountains and go down to the coast. So mostly iodine concentrations are going to be high in the ocean at the level of seafood. People who live in the mountains mostly are the one more susceptible for goiter. Food may interfere. We was talking about the goitrogens. So let's talk about the hyperthyroidism. We have the PTU and the metimazole. What they are doing this is to decrease the production or slow down the production of T3 and T4. Again, there are hyperthyroidism means too high T3 and T4 in your body. PTU or tapazole, they are going to decrease the production of more T3 and T4. But they are not going to affect the already existent T3 and T4 in the body. So that's why it's taking a while in order to make effect. Okay. Slow down the synthesis, hyperthyroidism, we are talking again for PTU tapazole, slow down the synthesis T3 and T4. This do not destroy T3 and T4 already produced by the thyroid gland. Okay, metimazole, never in pregnancy, as we already mentioned. Side effects, purpuric macular rash. Purpuric because they are, what is purpuric? Purpuric are small dots that appears in the skin, red blood dots appears in the skin because of this hyperthyroidism effect. And they can lead into what we call the bone marrow suppression. PTU can lead into bone marrow suppression. That means diminish all the red blood cells, can diminish the white cells, and can diminish what? The thrombocytes or platelets. So that's why it's coming the purpuric macular rash. Headache, nephrohepatotoxicity, BMS. That is what we were talking, BMS, the bone marrow suppression. Open eyes, open ears on that. Okay, so talking about the summary about the thyroid gland, we need to remember that the thyroid gland produces T3 and T4. Contraindications for medication of T3 and T4 is recent myocardial infarction, hyperthyroidism. The levothyroxine is going to last 24 hours. More than the natural thyroxine, T4, that produced by the body, full effect about 3 to 4 weeks. And one thing important about the T4, T3 medication. So when you're giving T3 and T4, when you want to give this medication, at night or in the morning. Mostly we want this on the morning, right? Why? Because more active. So you have more T3, more T4, you are more active. You start to do your activities. If you take it at night, you don't have more activities at night. So what is going to happen is going to keep you awake. It's going to take you awake. Antithyroid hormones can produce PMS. Highlight it, please. Okay, so one thing that we need to remember is that the medications, when there is endless questions about that, and I remember here that like a few years ago, is what is the difference, and probably we need to talk this too. What is the difference between the generic and the brand name, medication? So you go, for example, to some store and you see the generic name, and it's actually cheaper. Okay, and these medications are not such effective than the brand name marks medication. Why? Because it's obvious that they have less price because they don't have enough, those laboratories do not have enough study for pharmacokinetics and pharmacodynamics. So the absorption, the doses are going to be different. They're going to be at the end less effective than the brand name medication. That is the real thing. So that is how it is. Okay. All right. So let's keep going. So one thing before I finish with this portion of the thyroid is I want just to mention here. So we have three levels, right? Three levels. Three levels. Number one level is going to be the thyroid gland. Second level, the pituitary gland. The pituitary gland. Third level is going to be the hypothalamus. So primary hypo or hyperthyroidism, primary hypo or hyperthyroidism means that the problem is the thyroid gland. Secondary hyper or hypothyroidism, secondary is going to be the problem, the pituitary gland. And the tertiary level, tertiary is going to be the hypothalamus. So primary, thyroid gland problem. Secondary hypo or hyperthyroidism, the pituitary gland. Tertiary hypo or hyperthyroidism is going to be the hypothalamus. Okay, so let's start with the mineral corticoids and the glucocorticoids. And for this, we are going to do very brief but very a lot of substance here. All right, so I put it together because we have mineral corticoids. It's the same to say mineral. So what mineral we are talking about? The sodium. Okay, sodium. We have aldosterone that is produced by the body, and the fludrocortisone that is the medication that we are going to see today. Glucocorticoids, we have the cortisol, hydrocortisone, prednisone, the most common. Cortisol is being made by the adrenal gland. You and my adrenal gland produce cortisol. Hydrocortisone, they have the same potency of the cortisol of the body, cortisol. Hydrocortisone, so both of them they consider like potency 1. Prednisone is one of the most common medications that is given actually PO. Hydrocortisone can be PO, it can be IV. And prednisone is 5 times more stronger than the cortisol. Remember what are the actions of the glucocorticoids. First of all, mineral corticoids, let's start with aldosterone. Aldosterone, what is doing? Reabsorption of sodium. Okay, a reabsorption of sodium is a way that the body controls the blood pressure. Okay, so more sodium absorption in the kidney, more water coming in. So cardiac output volume go up, cardiac output go up, and the blood pressure go up. So it's a way to regulate, right? So if you don't want to, if the adrenal gland do not produce too much aldosterone, what is going to, there is less retention of sodium. Glucocorticoids, just to make a summary, number one, what is the main effect of the glucocorticoids is anti-inflammatory. Second, diminish the immune system. Number three, increase the glucose in blood. Number four, osteoporosis. Number five, gastritis. There's many of these effects are going to be having nursing considerations. The excess of cortisol, so we have, imagine the adrenal gland. You have an adrenal gland, you have a tumor in the adrenal gland. This tumor is in the cortex. For some reason, they can produce excess of cortisol. That is called the Cushing disease. Cushing disease. But if you overdose the patient, the adrenal gland doesn't have any tumor. But if the patient is receiving overdose of corticoids, that is going to lead into Cushing syndrome. That is different from disease. Cushing syndrome, overdose of corticoids. And Cushing disease is a pathology of the adrenal gland, mostly located as adenomas, lipomas, whatever tumors in the adrenal gland. Okay, so the administration of the mineral corticoids usually is once daily in the evening. Okay, daily, once daily in the evening. So it doesn't matter if you can give it actually in the morning or night. But that is the mineral corticoid. By the glucocorticoid, you can actually have to follow the circadian rhythm. The circadian rhythm. What is the circadian rhythm? Circadian rhythm is that you secrete more cortisol in the morning and less at night. That is our nature. So you need more cortisol in the morning than at night. The cortisol, what is going to do is increase the glucose in blood through the gluconeogenesis, and in order to have more sources of glucose. That is what giving us fast energy. Glucocorticoids, we need to taper the glucocorticoids, because if you give glucocorticoids medication, prednisone or hydrocortisone, or any other medication that you apply and put it into the blood, and you have a lot of cortisol in blood. So cortisol, corticoids are going to be high if you have high administration of those. So who knows that? The hypothalamus. Hypothalamus said, oh, okay, you have too much cortisol. Why I need to send more signals to the pituitary gland? So the hypothalamus will start to say, well, it's time to rest. I'm not going to send any information because you already have a lot of corticoids. But for some reason, the patient start to stop the medication suddenly. But for that, who's going to know? The hypothalamus. But the hypothalamus is kind of needs some time to recover in order to start producing again the cortisol. Meantime, talking about 2-3 days, they can make the patients totally miserable. They're going to be tired. They're going to be exhausted. As I said, they feel like 100 years old or more. So if you take the medication, the glucocorticoids, you can give 66% or three quarters of the medication in the morning. A 9, a 10, but in the morning. Okay, so 9 is about the time that everybody average wake up, right? Some people wake up at 6 o'clock or 7 o'clock, so probably it's the time to give it the medication at that time. And 1/3 of the medication at night. Why? Because we want to copy the circadian rhythm, more in the morning, less at night. But if you want to take the glucocorticoid once a day, which you prefer, to take it in the morning or take it at night? There's your answer. So in the morning. Okay, so we are going to see one thing we want to talk about is the cortisol. In addition of what we was talking, is that this guy is similar, is close, is like cousin from the aldosterone. So they look something similar. And the glucocorticoids, they have this ability to reabsorb sodium too. It's not the main characteristic, because the main characteristic is the increase of glucose, decrease the immune system, inflammation, gastritis, right? And these glucocorticoids can have some activity as aldosterone too, because they are very close chemically, and they can produce some retention of sodium. So this patient who has an excess of glucocorticoids can lead into edemas. So that's why we need to talk about electrolyte imbalance. You can actually INO, viral signs and symptoms of infection. Corticoids, please, corticoids is used for anti-inflammatory, not for pain. But what is going to do the corticoids, similar to the NSAIDs, is to cut the prostaglandins, especially to form more mucus. So if you have, for a long period of time, corticoids, you are going to develop gastritis, or you can develop an ulcer. So it's not a good combination with the NSAIDs, right? Because NSAIDs, they block to the prostaglandin and decrease the mucus of the stomach. All right, so test stools for blood, occult blood. Obviously, if you have some gastritis, you can have some bleeding. Bleeding in the stomach is being cooked by the gastric acid. It's called melena, and they can be detected in the stools. Implementation, we need corticoids increase the glucose in blood. So patients who are diabetic mellitus 1 or 2, they need to adjust, means increase the dose of insulin or the dose of oral anti-diabetic medication. So this is what I just mentioned. So as a summary, corticoids, 2/3, I said 3/4, I guess, 2/3, sorry, 60%. 60% of the dose at 9 o'clock and 1/3 of the medication in the afternoon. Mineral corticoids once daily in the evening. All right, so we have mineral corticoids is the fludrocortisone that is similar as aldosterone, right? So it's going to be used in order to have, they're going to give aldosterone. That is what it is. Treat adrenal insufficiency, adrenal Addison disease. Treat adrenal insufficiency, that means that you don't, adrenal gland is not producing anything because it's been destroyed, a disease, autoimmune disease, Addison disease, tuberculosis, for example. They are going to just, Addison disease is adrenal insufficiency. The causes are some destruction, for example, we have tuberculosis or one infection. So you don't produce anything, so you need to give medication. In this case, the fludrocortisone is going to be like treatment replacement of the aldosterone. All right, so therapeutic nursing. So here we have the signs, some side effects that we need to remember: chest pain, confusion, dyspnea, productive cough, weight gain, and that is caused by this aldosterone. What is doing the aldosterone? Reabsorb sodium, so more fluid, edemas. Adverse effects, we have hypernatremia and hypokalemia. Corticoids. Patient education for corticoid therapy, increase potassium intake, decrease fluid intake because the retention of fluids, change position at least 2 hours. When these have edemas, they are going to produce some ulcer of pressure ulcers. Okay? All right, so electrolyte imbalance, fluid accumulation. So how to prevent fluid accumulation? Mostly we need to be giving half of the volume with the meals, half of the volume with the meals, and the remainder divided in between shifts. So how much volume you're going to take? 1500 ml about. All right, so glucocorticoids. What is need to be relevant here is that decrease the inflammatory process. And for healing processes, we need inflammation. If you have glucocorticoids, they are going to decrease inflammation. It's going to take more time to heal the wound. One question that's always being asked is about Cushing syndrome. So you have somebody who has arthritis, and suddenly start to develop Cushing syndrome. So what is the situation? Are we going to diminish or increase or maintain the same dose? The answer is to maintain the same dose, because even though that the appearance is going to change, it's more aesthetic concern, but the main problem is the disease, arthritis or lupus or whatever is going to be autoimmune disease. So you are going to maintain the same dose of the corticoids. Interactions, we have corticosteroids may enhance the loss of potassium. Warfarin can enhance or decrease, so either way, we don't know. So how we are going to check warfarin with PT or INR. Oral anti-hypoglycemic agents, we need to increase the dose of insulin of hypoglycemic agents because the corticoids increase the glucose in blood. Signs of infection may be evident. First of all, general malaise, sore throat, low grade of fever. So here, by sure, if you have low grade fever, you start to suspect. Second, sore throat. the most common system for infection is going to be the respiratory tract. Of course, you're not going to be happy feeling that, so you feel malaise. All right, so produce suppression of immunologically. Corticoids do not have analgesic effect. Please remember this. Glucocorticoids increase the glucose in blood. We have the tapering of the steroids. It's very important. Okay, so we have a patient receiving a higher dose of period of time of corticosteroids is susceptible to psychotic behavioral changes. If somebody of you, and don't tell me who, you receive hydrocortisone, for example, in asthma attacks or crisis, you will see, for example, we give to the patient about four injections intramuscular for hydrocortisone of 40 milligrams, 20 milligrams, sorry, 20 milligrams a time, four times in a day. The patient is having tremors, is agitated, is irritable, is ready to jump and fight. And that is one of the side effects of the corticoids. All right, so let's talk about the desmopressin and vasopressin. Those guys are going to be used for diabetes insipidus. Okay, so we already talked about diabetes insipidus is not diabetes, right? It's not diabetes. It's diabetes because they have the same signs, similar signs and symptoms of diabetes, but it's not. Insipidus because don't taste. Well, nobody tastes it, but the insipidus is just trying to tell that there is no sugar in the urine. Okay. So here we have the vasopressin is actually the ADH. Vasopressin, Desmopressin, DDAVP, Pitressin, those are ADH, ADH, antidiuretic hormone, all of them. So diabetes insipidus, you pee a lot. You give antidiuretic hormone, ADH, you control the boiling, right? So, or the urination. Why is called vasopressin? Vasopressin is because they have two functions, the ADH. The ADH has two functions. Number one, you already know, the reabsorption of water at the level of the collecting ducts and distal convolutive or especially collecting ducts. And the other one is a vasoconstrictor. Yes, it's going to be a vasoconstrictor. The ADH can be having properties of vasoconstriction. Okay. All right. So prevent or control polydipsy. Why polydipsy? Why polyuria? Okay. First of all, if you have ADH, you don't pee as before, right? So polyuria is going to be controlled. Secondary to that, if you don't have polyuria, you don't have polyuria. You are not as thirsty because polyuria, what it's doing is losing urine, water, and as a consequence, you start to be more thirsty, polydipsy. Lithium may decrease the effect of the vasopressin. So again, OCD, the obsessive compulsive disease, we are going to use lithium, and that can decrease the effect of the desmopressin. Okay, let's talk about the somatropin. Somatropin, we need to, somatropin is the somatotropic hormone, is the growth hormone. So what is the treatment for? To grow, right? To grow. And who's suffering from lack of growth? The dwarfism. That is called the hypopituitary dwarfism. You need to use in very careful with in acute and chronic diseases like migraine, epilepsy, and asthma. Why? Because they are going to increase the effect of the migraine. Somatropin is a patient having migraines, and the patient receiving somatropin, the migraines are going to be really, really bad. The threshold for epilepsy are going to decrease, so it's easier the patient to start having seizures. So be careful and with the patients who are receiving somatotropin and having epilepsy. And the same for asthma. It's going to exacerbate and make it worse asthma attacks. Okay, so that's why it require require close monitoring. The octreotide, the sandostatin. So listen. Somatropin is growth hormone, in other words, and the octreotide is the opposite. It's going to inhibit the growth hormone. Again, somatotropin is going to have activity of growth hormone, and the octreotide is going to inhibit the growth hormone. So we have acromegaly. Acromegaly is the patient start to grow without any control. They can produce carcinoid crisis. Carcinoid crisis is when the cancer can lead some factors that can lead into flashes and can produce some especially heat flashes on the face and some rash on the skin. They can be used for esophageal varices, and that's it, I guess. So one thing is we need to just remember that we have some well, actually that's all what we are going to talk today, and that is about the lecture for today. All right, so I really want to thank you everybody for your patience and for your to attend to this webinar. All right, thank you so much. So any question? Let me open the audio. Dalina, thank you. Depika, thank you. Shelny, thank you. Soli, thank you so much. Any question?
No questions. Thank you, Dr. J.
All right, everybody have a good night, and I will see you Friday. Thank you so much for attending to the webinar. I will post it in the next few hours. Muchas gracias. Thank you. See you next time.
Thank you. Good night.
Good night.